Hi, everyone. My name is Sherry Wiley, and I am the Mobile Crisis Team Administrator for Youth and Families at Healthcare Authority. My most recent experience involves delivering and supervising youth mobile crisis intervention and stabilization here in Washington State. Today, I'm going to go over the youth crisis model, known as Mobile Response and Stabilization Services, or MRSS. Both SAMHSA and NASBID recognize this model as best practice, and it's being delivered successfully in several states. When people think of crisis, they think of active rescue, which is important. But youth and young adults make up a significant amount of the population in Washington accessing crisis services. The reality is that exhausted parents are sitting in emergency departments for days with their kids waiting for a bed, only to abort out of frustration, or sometimes having low acuity adolescents and being admitted to inpatient. Once seen, there's rarely aftercare in the home or community. This slide highlights the difference between youth and adult mobile crisis response models. We want to make sure that when a parent or caregiver calls, they get an in-person response. A parent doesn't need a list of more numbers to call. They need something that looks like help. And sending an in-person response to a youth in crisis will support the caregiver's ability to respond to that crisis. We want to avoid law enforcement response, to send the youth mobile response teams, and we want to keep kids at home rather than transporting to inpatient facilities. The goals of MRSS are to support and maintain kids in their natural environment. They sleep in their beds at home, not in facilities, and they return to school where the team can do care coordination with educators and school supports. Youth mobile response teams include robust engagement and outreach efforts, and they maintain partnerships with all child-serving systems of care and other providers. Teams promote safety in all environments the kids are in. They can create safety plans, secure the home, increase supervision depending on needs. They can create a safety plan for the school or the daycare and get all providers using common language. The family will have access to the team 24/7 for immediate response to any location the youth is. The teams will reduce contact with law enforcement and emergency departments or detention centers. And youth teams should go first as standard protocol instead of DCRs. Teams will assist families by identifying community and natural supports and provide warm handoffs to additional clinical supports if needed, or to the stabilization phase of MRSS. We sometimes hear there are no youth in crisis, or there isn't sufficient call volume to support a youth team in certain regions. These represent some of the systems that currently involved with youth and families, and these systems can all identify needs early and intervene early and refer to youth teams. Once we have teams in each region, they can do outreach and locate kids falling through the cracks. Schools, pre-K to 12, are primary stakeholders in the youth crisis system, and they remain primary feeders to the emergency department. Best practice is that when law enforcement contacts a youth in crisis with behavioral health needs, that they call the youth mobile crisis team first. We want true justice system diversion for kids. Someone to respond. When a youth team gets a referral, there's initial response, which is face-to-face and within 2 hours, with follow-up available for the next 72 hours. Since this may be the first point of contact a family has with the behavioral health system, the team should build a trusting relationship of mutual respect and provide individualized care that includes family voice. For the somewhere to go piece in SAMHSA's vision, this model understands that kids get better in their natural environments. So a place to go isn't necessarily a brick and mortar facility, but rather an in-home stabilization phase, which MRSS provides. This phase can last up to 8 weeks, and this gives the team and family time to focus on inherent strengths within the family and do care coordination with schools, other providers, any systems the family is interconnected with, and connect the family to ongoing clinical supports if needed. The team can identify natural supports or activities the youth is interested in and help connect the family to their community for true recovery. The natural supports and community connections offer alternatives for a place to go, like sporting events, music, arts, 4-H activities. These become natural respite opportunities for the family. This slideshow shows where the current youth and family teams are in Washington State. The current teams are located where the smiling faces are at. With some proviso funds from last year, we have sent out funding for the BHASOs to stand up at least one youth team in each region. With the rollout of 988, we'll need to continue adding more to ensure that the capacity is there to meet increased demand and do outreach. While we added one team to each region, we're going to need more. While all kids get access to the 72-hour crisis intervention component, which is insurance blind across Washington State, not all kids get in-home stabilization, and those that do get it through braided funding that includes county tax initiatives, and it's just not sustainable. Work is being done with the state plan to allow up to 8 weeks of in-home stabilization for Medicaid youth, but non-Medicaid kids and commercially insured kids tend to have higher acuity and need longer stabilization phases because of the lack of private providers in the region. This graph on the left shows you visually what happens when kids enter the crisis system. All youth get that initial response. It's insurance blind. It lasts for up to 72 hours. There's only 2 regions doing in-home stabilization. One is King County, and that's for Medicaid youth, and Thurston and Mason County have in-home stabilization for up to 77 days, regardless of payer. Imagine your kid discharging from the ER after an attempt. We would want to ensure equity in service in all regions. For the future state, not only would we have enough youth teams in each region, but we would also have a way to fund the in-home stabilization piece fully. We need recommendations from the CRIS committee to do this. More barriers and gaps to consider include workforce challenges and orienting the crisis system as a whole to the needs of youth and families. We want to shift the paradigm so that all schools, primary care providers, and mental health providers refer directly to the youth team instead of sending kids to the ER. Another key interruption point is if the ER needs a DCR evaluation, they can send a youth team first. And if the youth team determines that a DCR is in fact needed, they will do a warm handoff to the DCR. We want to coach ERs and law enforcement to refer directly to youth mobile response teams. We are working on training youth teams in developmentally appropriate interventions and providing guidance in outreach and engagement efforts. While in-home stabilization remains the best practice model for youth, occasionally they have a level of acuity that requires inpatient treatment. There are some inpatient facilities scattered across the state, and the Department of Commerce is putting out a notice of funding opportunity for 2 youth facilities. This will be a 90-day facility, one on each side of the Cascades. And then there's another notice of funding opportunity for 2 possible youth 23-hour units. As a reminder, these units will provide an alternative to the ER for families for a quick evaluation and assessment. And all facilities should discharge to youth crisis teams for safety, follow-up, and care coordination to prevent return to the pre-crisis phase. This slide has some questions for the CRIS committee for feedback, primarily related to funding the youth mobile crisis teams and ensuring that stabilization is funded fully for the entire 8 weeks for all families across Washington. This slide has some links to national best practice models being used in other states successfully You'll notice a significant cost savings in inpatient treatment and emergency room boarding. Thank you for your time, and here is our contact information for the Crisis Systems team here at Healthcare Authority. If you'd like to follow up with any questions, we'd love to hear from you. Thank you.